Thank you for the invitation to present on the World Health Organization's strategy for the prevention, monitoring, and response to HIV drug resistance. I have no disclosures or conflict of interests. At the end of 2020, 27.5 million people were receiving antiretroviral therapy globally for the treatment of HIV infection. Despite increasingly potent and well-tolerated regimens developed over the last 20 years, the emergence of HIV drug resistance can compromise the effectiveness of antiretroviral drugs in reducing HIV incidence and HIV-associated morbidity and mortality. Drug-resistant HIV is selected for when the virus replicates in the presence of antiretroviral drugs. If measures are not put in place to minimize HIV drug resistance, drugs used to prevent and treat HIV infection may become compromised or become ineffective in the future. In 2019, WHO's report on HIV drug resistance showed high prevalence of pretreatment HIV resistance to efavirenz and/or nevirapine among adults initiating or reinitiating first-line ART, exceeding, in fact, 10% in most low and middle-income countries that reported data. This finding in adults is one of the main reasons to accelerate the use of the integrase inhibitor dolutegravir in combination with lamivudine and tenofovir as a fixed-dose combination known as TLD. With respect to infants infected with HIV, the 2019 report showed that 1 out of 2 newly diagnosed infants have HIV with efavirenz or nevirapine resistance, underscoring the need to accelerate the transition to optimized non-NNRTI ART regimens in infants. These high levels of pretreatment drug resistance highlight the need to fast-track transition to dolutegravir-based regimens for infants and children whenever possible. This slide provides a historical overview of the WHO HIV drug resistance strategy. In 2004, WHO collaborated with HIV ResNet, a global network of experts providing technical and strategic advice to WHO on drug resistance, to develop the first strategy for assessing, preventing, and monitoring HIV drug resistance. This strategy was revised in 2012 and again in 2015. The 2021 update further refines the strategy and considers the lessons learned from implementing surveys of drug resistance and the implementation of the Global Action Plan on HIV drug resistance 2017 to 2021, as well as ongoing scale-up of ART and pre-exposure prophylaxis for the prevention of HIV infection, and includes transition to new regimens. The 2021 WHO drug resistance strategy provides a core set of recommended activities to be implemented at country level. These activities include the development and implementation of national action plans on HIV drug resistance, the monitoring of quality of care indicators associated with viral load suppression and drug resistance. These indicators are also known as early warning indicators of drug resistance, and finally, the implementation of drug resistance surveys. In the subsequent sections of this presentation, I will examine key aspects of the global HIV drug resistance strategy. To start, it is critical for a country to develop a comprehensive national action plan aimed at the prevention, monitoring, and response of drug resistance. Such a national action plan provides a framework for concrete action to minimize emergence and transmission of drug-resistant HIV at country level, and is expected to guide the implementation of critical activities aimed to protect the investment and progress made by ART programs in countries. For sustainability, the National HIV Drug Resistance Action Plan should be situated within the broader HIV and health sector strategies and should aim to synergize with national antimicrobial resistance plans. To develop and implement a national action plan on HIV drug resistance, WHO recommends that countries develop a 5-year plan aligned to these 5 strategic objectives. These 5 strategic objectives are listed on this slide and include prevention and response, monitoring and surveillance, research and innovation, laboratory capacity building, and governance and enabling mechanisms. Health ministries should develop national action plans on drug resistance through a consultative process with input from national stakeholders to increase awareness, advocacy, political and programmatic commitment, and also to facilitate resource allocation to tackle drug resistance. The second key element of the WHO HIV drug resistance strategy is monitoring. Specifically, WHO recommends assessing whether ART programs deliver services with the quality required to minimize the emergence of drug-resistant virus through the monitoring of early warning indicators of HIV drug resistance. Early warning indicators use standardized definitions which have evolved over time as programs mature and public health actions are refined. Indicator monitoring should be integrated into routine monitoring and evaluation systems of ART programs. This minimizes cost and strengthens existing data collection and recording processes. In countries in which the early warning indicators are not systematically and routinely collected in all clinics, or quality of the of available data is poor or unreliable, early warning indicators may be monitored through a special survey. This slide provides us with a very high-level overview of recommended early warning indicators of HIV drug resistance. Although 4 indicators remain unchanged in 2021, there have been some changes. The indicators that remain the same are viral load testing coverage, ARV medicine stockout, ART adherence proxy, and appropriate switch to second-line ART. Notably, the updated 2021 recommendations include 3 new indicators. They are total attrition from ART, which measures progress toward promoting retention amongst individuals receiving ART and mitigating loss. This indicator replaces the former indicator of retention at 12 months. The 2 additional new indicators are people living with HIV who have viral load suppression and appropriate second viral load test. The third key element of the HIV drug resistance strategy is drug resistance surveillance. In the 2021 strategy update, the document includes updated methods for surveillance of acquired HIV drug resistance, specifically a new viral load laboratory-based method and an updated ART clinic-based method. The 2021 strategy also recommends surveys of acquired of HIV drug resistance in countries scaling up pre-exposure prophylaxis for the prevention of HIV infection and the monitoring of resistance to integrase inhibitors, including dolutegravir. I will now focus on surveys of pre-treatment HIV drug resistance. The survey of pre-treatment HIV drug resistance is designed to generate estimates of HIV drug resistance amongst all ART initiators and amongst ART initiators without prior ARV drug exposure. Results from this survey type inform national and global guideline development processes and ensure the selection of effective first-line antiretroviral therapy regimens. The average sample size for this survey is around 400, and surveys are designed to be implemented every 3 to 4 years. The survey sites are clinics providing ART, and they are sampled at random using probability proportional to size sampling. Patients are consecutively enrolled over a 3-month period, and after HIV drug resistance testing analysis is performed, simple proportion with confidence intervals adjusted for clustering are calculated. Results should be disaggregated and reported by age, gender, and prior ARV drug exposure. This slide summarizes WHO's method to assess drug resistance in infants. By way of background, HIV drug resistance can be transmitted from an HIV-infected mother or selected due to use of antiretroviral drugs for the prevention of mother-to-child transmission at delivery, postpartum. Therefore, this may be either neonatal prophylaxis or maternal ART. Fortunately, scale-up of antiretroviral drugs to prevent mother-to-child transmission have led to far fewer infected infants. However, some proportion of children infected despite PMTCT interventions may have virus resistant to 1 or more antiretroviral drugs used for treatment. This survey uses sites for this assessment, specifically early infant diagnosing testing labs in countries. All EID or early infant diagnostic testing labs in the country contribute specimens during a 3-month period. From each EID lab, a sample of remnant EID specimens from children testing positive is selected using systematic sampling. Sampling is proportional to the size of the laboratory. After HIV drug resistance testing, minimal variables are abstracted from the EID requisition forms and data analysis is performed. The prevalence of resistance disaggregated by ARV drug exposure, be it child or maternal, and by breastfeeding status is calculated, as is the proportion of infants with and without and with unknown PMTCT exposure. WHO recommends the sample size of around 500 EID specimens, and in countries with fewer than 500 specimens available, a census is suggested. The 2021 WHO updated strategy also includes new surveillance methods for acquired HIV drug resistance. This is HIV drug resistance in people taking antiretroviral therapy who have unsuppressed viral loads. The 2021 update accommodates the transition to dolutegravir-based ART underway in most high-burden countries. Additionally, it acknowledges that the rate of transition varies from country to country, and that in some respects, country transition may be delayed for a variety of reasons. The survey method acknowledges the need for robust estimates of dolutegravir resistance to facilitate monitoring of trends over time. And finally, the methods will yield programmatically actionable estimates of acquired resistance in people taking non-dolutegravir-based regimens as well. The goal of surveillance of acquired resistance is, of course, to provide nationally representative estimates of the prevalence of drug resistance in populations receiving ART in order to inform second and third line regimens, as well as to establish program performance in achieving levels of viral load suppression suggested by WHO and UNAIDS. The outcomes are listed on this slide and include the prevalence of acquired resistance amongst adults and children receiving ART, as well as adults and children receiving dolutegravir and non-dolutegravir containing regimens. This slide will help us to understand which method is applicable for a given country. If viral load testing coverage is less than 60%, then recommended survey method will be the updated ART clinic-based method. However, if viral load testing coverage is equal to or exceeds 60%, a country then assesses if the required policies documented in the left lower hand corner of the slide are in place. Specifically, national policies requiring routine viral load testing of individuals and appropriate laboratory infrastructure to store and test remnant viral load specimens. If required policies and infrastructures are not in place, the country conducts the updated ART clinic-based survey method. If these policies and infrastructures are in place, the country goes on to implement the new laboratory viral load testing-based ARD survey method. First, I will focus on the updated ART clinic-based survey method. Remember that this method is applicable in countries where viral load testing coverage is less than 60%. The clinic-based approach uses a method known as a two-stage cluster design, in which a sample of clinics is first selected from a list of all clinics providing ART in a country. Clinics are sampled using probability proportional to size sampling, and in the second stage, a sample of eligible patients is recruited from each of the selected clinics. The patients are included in the survey will have blood specimens collected for viral load testing. Specimens with viral load greater than or equal to 1,000 copies per milliliter will be genotyped to assess for HIV drug resistance. Minimal demographic data are abstracted for each patient, and data analysis is performed with calculated prevalence estimates weighted for confidence intervals. Notably, surveys in adults and children and adolescents are conducted simultaneously. I will now focus on the viral load laboratory-based ADR survey method. This is the preferred survey method for acquired drug resistance surveillance, as most countries are likely to have achieved viral load testing coverage in excess of 60%. In this method, we leverage remnant viral load specimens from people with viral non-suppression To minimize bias, all viral load laboratories in a country participate and store remnant specimens from people on ART. Notably, the survey is designed to be implemented in adults and children with surveys conducted simultaneously. The recommended survey period is 3 months. After each lab genotypes, remnant specimens, data analysis is performed after minimal variables are abstracted. Point prevalence estimates which are weighted for acquired resistance are calculated. In 2015, WHO recommended that oral pre-exposure prophylaxis, or PrEP, be offered as an additional prevention choice for HIV-negative individuals at substantial risk of HIV infection as part of a combination HIV prevention approach. The risk of HIV acquisition is substantially reduced in PrEP users, but those who do become infected are at risk of drug-resistant virus. The primary outcome of the survey of acquired drug resistance in PrEP users is the prevalence of predicted tenofovir and/or 3TC or FTC resistance amongst those diagnosed with HIV during the survey period who have taken an oral tenofovir-based PrEP regimen at any time in the previous 3 months and who have a drug resistance genotype available. Results should be disaggregated by gender, age, PrEP regimen, and dosing strategy. As new PrEP regimens become available, the outcome, of course, will expand to assess the prevalence of resistance to newer PrEP drugs and drug classes. This slide provides a quick overview of the method. Because HIV infection is expected to be very infrequent amongst PrEP users, a census of all eligible individuals will contribute information. A total number of individuals to be enrolled is expected to be below 500. Ideally, all PrEP sites in the country should participate in the survey. The survey enrollment period is 12 months, and after drug resistance testing, survey outcomes should be disaggregated by gender, age, PrEP regimen, and dosing strategy. WHO has a number of enabling mechanisms in place to support quality-assured genotyping for use of results for public health purposes. WHO strongly advises that HIV drug resistance testing of specimens collected for surveys be performed by a laboratory designated by WHO for this purpose. This supports quality assurance, quality control, and provides confidence to country decision makers with respect to the accuracy of genotyping results. More information on the WHO HIV drug resistance laboratory operational framework and strategy may be found at the link presented on this slide. To conclude, the goal of WHO's HIV drug resistance strategy is to prevent, monitor, and respond to HIV drug resistance. WHO promotes the dissemination and sharing of health data, including surveillance and epidemiological information. The primary purpose of data sharing is to advance public health by permitting analysis that enables the fullest possible understanding of health challenges, to help develop new solutions, and to ensure that decisions are based on the best available evidence. First and foremost, HIV drug resistance and quality of care data generated by countries should be used for national reporting and to guide national public health and ART program decision-making. In addition, WHO regularly produces a global report on HIV drug resistance prevalence and trends based on information shared by countries. The results of HIV drug resistance surveys have been used to inform national and global policies and to optimize first and second line ART regimens and have guided the fast-track transition to dolutegravir-based ART. Therefore, countries and national drug resistance working groups are encouraged to promptly disseminate HIV drug resistance survey findings with national and international stakeholders, to use the results to provide evidence-informed advocacy tools for action on HIV drug resistance prevention and response, to inform national policies on ARV drug selection, and to improve ART service delivery and ART program functioning. With that, I conclude, and thank you very much for the invitation to speak today.